Hello friends, this is Dr. Rakesh Mittal, Senior Consultant in Surgery, and today I am going to discuss with you the recently conducted INICET exam last month in 2022, the surgical questions, right? The questions were very easy and more than 95% of the questions were directly from our content videos on surgery, the main videos, right? Now in this lecture, I'll be showing you the questions with exact language and the exact choices. We have collected the questions from various sources and we have made the best efforts to bring you the best question, the proper language and the exact choices and the exact image. Right? So we'll be discussing the questions now. So first is Hammond sign is pathognomic of, very easy, straightforward question. It's seen in pneumomediastinum. Pneumomediastinum means free air in the mediastinum. Hammond sign is basically it's mediastinal crunch. It's an auscultatory finding. When you auscultate the chest, the pericardium area, the mediastinal area, because of air in the mediastinum, you will hear a crunchy sound. So that's pathognomic of pneumomediastinum. Now, pneumomediastinum is seen in why there is air in the mediastinum when the esophagus ruptures. So this is main finding of esophageal rupture. Spontaneous esophageal rupture, which is also known as Boerhaave syndrome. So another question related to it, Boerhaave syndrome, which is nothing but spontaneous rupture of esophagus. And why esophagus ruptures? Because of barotrauma, because of high pressure inside the esophagus. It ruptures at its weakest point. So the next related question, the point of rupture, that's lower 1/3 above the gastroesophageal junction, and precisely it's the left posterolateral wall in lower 1/3 of esophagus. In contrast to this, the instrumental, the endoscopic related esophageal ruptures, they happen in the upper 1/3, that is cervical esophagus. So these are the main questions related to this. So all these questions which have been asked recently in NEET or INICET exam have the high potential of being repeated in the subsequent exams. Now the next question, the following number in this tube is indicative of, all of you have seen, this is a Foley's catheter, and on the proximal end of this some number is written which is mentioned as the number with F, that is French size. It can be 10 French, 12 French, 14 French and so on. Now what is this? What does this number indicate? This indicates outer diameter of the tube, or indirectly this can also be described as circumference of the tube. Outer diameter or the circumference of the tube. Now what is the outer diameter? Usually the French size divided by 3 in millimeters. So 1/3 of this number in millimeters roughly is the size of the tube, that is outer diameter. So if it is a 16 French tube, so the outer diameter will be 5.33 millimeters. So that's how we calculate it. So again, very easy and straightforward question. Okay. Which of the following statements is false regarding central or peripheral venous access? So let us look at the choices one by one. Phlebitis is a common complication of peripheral venous access. This is very easy. That's in fact the most common complication, the thrombophlebitis of when you put a cannula, there is redness around it. So that's phlebitis. So this is true. Okay. Now choice C, in case of AV fistula, peripheral IV cannula is avoided. That is again true. If there is a fistula in a limb, we should not put a cannula in the same limb. So that's again true statement. Now, isotonic saline and diluted heparin are periodically used to flush the venous excess to maintain patency. All the peripheral cannulas or even the central ones, the blood gets clotted if we don't use them for some time. So they have to be repeatedly flushed either with simple saline or we can use diluted heparin solution. So this is again true. So now we are left with one choice. So let us see this. In septic shock, vasopressors are initiated through the central venous access to avoid gangrene of the limb. Now this statement is a bit tricky. It is partially true to some extent, but not entirely. So now in septic shock, vasopressors are given, but initially in most of the patients they are started using a peripheral cannula, but they again they should not be given through the peripheral cannula for a long period. Reason being, through the peripheral cannula there can be leakage or extravasation of the vasopressors into the surrounding tissues that can cause necrosis and hence the gangrene. So ideally you should use central venous access only, but initially may be given for a very short duration through the peripheral cannulas also. So this statement is partly true. So out of the four, the best choice and the answer would be choice B. Okay, next question. Match the following sutures with their appropriate use. Now, first of all, you should know the main sutures, whether the suture is absorbable, non-absorbable, and what material it is made up of, right? And then, so you have to mix and match with the sutures. One suture may be used in more than one choices. So now we have to make a best combination out of this. So let us see them one by one. So this is polypropylene. Polypropylene, popularly known as Prolene brand, and this is non-absorbable suture. Polyglectin is absorbable suture. Polydioxanone is slowly absorbable, and nylon is again non-absorbable. Now, one is the material, second the size also makes a difference. So let us look at them one by one. So 2,0 polypropylene, it's a non-absorbable sutures. 2,0 moderate thickness, not too thick, not too thin. So bowel anastomosis, no, right? Now polypropylene for fixation of the mesh to the inguinal ligament in the Lichtenstein repair of the inguinal hernia, we do use some non-absorbable suture, and the most preferable one is polypropylene, right? So it fits here. We are talking about only first choice at the moment. Closure of the skin, we do need a non-absorbable one. So we can use polypropylene, but not routinely we use, because it doesn't have good knotting property. The knot doesn't fit well, it tends to slip, plus it's a 2,0 size. We prefer to use a thinner suture for skin closure, that is 3,0 is preferable. So no for this. Closure of linea alba in a laparotomy. Again, to close the linea alba, we do need a non-absorbable one, but we do need a real thick one. So 2,0, no. Had it been number one, so I could have used it, but 2,0, no. Okay, so we are left with just one choice. So A fits with 2. Okay, let us see the other choices. Okay, then 3,0 polyglectin. It is absorbable. It is Vicryl, very popular brand. Now, Vicryl or polyglectin, bowel anastomosis, perfect. Size as well as material. It's absorbable, and 3,0 is the perfect size. Okay, fixation of mesh, always use non-absorbable. So no. Closure of skin, again we need non-absorbable. So no. Closure of linea alba, again non-absorbable. So this choice is the easiest of all. So B is 1, right? So that's a best match for the polyglectin. Now choice third, the number one. So number one, that means it's quite thick. Loop of polydioxanone. Polydioxanone is a slowly absorbable suture. So now choice 1 and choice 2 are already gone. So closure of skin and closure of linea alba. I've already explained to you. For skin, we need a thinner suture. For linea alba, we need a thicker suture. So number 1 fits into this, right? So C is 4. And the last is 30 nylon is good for skin closure. So D is 3. So this is the best match. So the answer here would be B, right? So this is how we, whenever you next time you might get a different combination of sutures and different choices of procedures. So this is how you match. Look at the material, whether it's absorbable, non-absorbable, what are the properties and what is the size, it's thicker or thinner, then match them with the choice of procedures. So this is, I have already explained to you. Okay, next question. Which of the following conditions are seen in multiple endocrine neoplasia men 2A syndrome? Men 2A syndrome. You know about men syndrome. There are three types: men 1, 2A and 2B. Men 1 is also known as Wermer syndrome. Men 2A is also known as Sippel syndrome. Right. So let us first revise the men syndrome. As I told you, men 1 is Wermer syndrome and men 2 is Sippel syndrome. Okay. Now men 1, the best way to remember is, the way I remember it is triple P. Triple P, basically men, as the name suggests, multiple endocrine neoplasia. So it's a combination of multiple endocrine tumors along with some other non-tumorous manifestations, right? So that's a combination of tumors: pituitary, pancreas, parathyroid, triple P. So 1P, pancreatoenteric neuroendocrine tumors, right? Second P, pituitary tumors, right? So pancreatic, pituitary, and third P is parathyroid tumors. So triple P. The other non-endocrine manifestations: lipomas, angiofibromas, cholangiomas, ependymomas. Okay. Now men 2A, the mnemonic I use is TPA: thyroid, parathyroid, adrenals. That's a combination of tumors: thyroid, parathyroid, adrenals, right? So thyroid, so T, this is medullary thyroid cancer. That's an endocrine form of thyroid tumors. You know it, more than 95% chances, right? And then parathyroid, so that's a P. And then pheochromocytoma, adrenal, that is A. So that's a combination in men 2A, that is TPA. And the non-endocrine manifestations: amyloidosis and Hirschsprung's disease. Now men 2B is remove P from TPA. So now we are left with just T and A, thyroid and adrenals. So pheochromocytoma plus you can add to this medullary thyroid cancer. So combination of thyroid and adrenal. And the non-endocrine manifestations: mucosal ganglionomas and marfanoid habitus. So that's the complete summary of men syndrome. Now go back to the question. Men 2A. 2A is thyroid, parathyroid and adrenal. So parathyroid is seen, medullary carcinoma thyroid is seen, caveolate spots are not seen, all of you know, they are seen in neurofibromatosis. Optic nerve glioma is again not a feature of men syndrome. So the choice here is, what do we see? Only 1 and 2, that is combination of medullary and parathyroid tumors. So this is about men. So move on to next question. A 36-year-old lady presents with breast lump, diagnosed of breast cancer. Which of the following immunohistochemistry results are seen in basal-like? So that's the thing. What has been asked? The IHC markers. immunohistochemistry. And what is the type? Basal type. So there are multiple types based on the molecular classification of breast cancer. Very, very important question, and it has been taught for so many years, and focus on this, that you must know the molecular types of breast cancer. Okay, so basal like is also known as triple negative type. Triple negative. So before going on to this, as there are in the choices, you know the receptors important for breast cancer. The ERPR, that is estrogen and progesterone receptors, and then HER2 new receptor. Now remember, ERPR are friendly receptors for the tumor. Presence of ERPR makes the prognosis better. So it's a friendly receptor. That's the best way to remember it. That's the way I remember it. Right? HER2 new is an enemy for the patient. Right? So ERPR, presence of ERPR makes it a better prognosis tumor. Presence of HER2 new makes it poor prognosis. Absence of HER2 new, good prognosis. Absence of ERPR, poor prognosis. So presence of friend, absence of friend. Presence of enemy, absence of enemy. So this is how the various permutations and combinations are made. Let me show you the classification, the real molecular classification of breast cancers. So these are the 4 types, and this is mandatory, you must know it. Luminal A, luminal B, HER2 new enriched, and basal like. Luminal A and B are very similar in the receptor status. ERPR is positive in both, HER2 new is negative in both. So they are better tumors because presence of friendly receptors, absence of enemy receptor. But there is only one difference, and that difference is in the level of Ki67. Luminal A has low Ki67, whereas luminal B has high Ki67. So that's a marks the prognosis, right? So prognosis is bad for luminal B compared to luminal A. So luminal A has the best prognosis. So another question, which type has the best prognosis? Perfect situation. ERPR positive, HER2 new negative, low grade tumor with low Ki67. So overall 5-year survival rate is 90%. So best prognosis. Luminal B, because of high, the receptor status is good, but high Ki67 levels, so the grade goes to intermediate to high, so prognosis goes down. Now the remaining 2, right? So ERPR are absent in both of them. The difference is in HER2 new. Now the trick to remember is HER2 new enriched. HER2 new enriched automatically tells you that there is positive HER2 new. Positive HER2 new, but ERPR negative. Again, worst prognosis. Okay, so prognosis is much improved, but only with the treatment for HER2 new receptor, that is trastuzumab, that is monoclonal antibodies. But otherwise, looking at the receptor status, they are bad tumors. And basal like, the best way to remember this is triple negative. Automatically tells you all the 3 receptors are absent. So ERPR negative, HER2 new negative, right? So this is how we remember, the easy way to remember the molecular types of breast cancer. So it's a triple negative. So answer here would be ER negative, PR negative, HER2 new negative. Okay, another question on breast cancer. All of the following are the relative contraindications for breast conservation surgery except breast conservation surgery or BCT or BCS, that is breast conservation therapy. Now, breast conservation surgery is something where, compared to the older techniques of operating breast cancer, that is mastectomy, either simple or modified radical or radical mastectomy, where entire breast has been removed. But now the new thing has come up, that is breast conservation surgery for last 10 to 20 years approximately, where now all the focus is on preserving the breast, right? Preserving the breast, just remove the tumor. So what could be the forms of breast conservation surgery? So lumpectomy, or wide local excision, or quadrantectomy. These are the three types of breast conservation surgery. So we remove the tumor ideally with a 1 centimeter margin, right? Okay. Now BCT can be done for stage 1, stage 2 and even early stage 3 cancers. So stage 4 is metastatic, so no surgery at all, right? So 1, 2 and early 3, that is 3A or some cases of maybe 3B also, after downgrading the tumor. So these are the indications. In these patients, we can use breast conservation surgery depending on the other factors. Now the next question comes, which has been asked here, the contraindications for breast cancer. The contraindications: first, large tumor, more than 4 centimeter approx. Larger the tumor, more difficult it will be to conserve the breast, but more than the size of the tumor, it's tumor to breast ratio, which is more important than this, right? A 4 centimeter tumor in a 10 centimeter breast, 4 centimeter tumor in a 20 centimeter breast. So the ratio changes, right? So in a bigger breast, even a bigger size of tumor can be offered breast conservation surgery. But for a smaller breast, you cannot offer BCS for every tumor, right? So more than just the size of the tumor, more important is tumor size to breast size ratio. Then centrally placed tumors are difficult. Not, this is not an absolute contraindication. Remember, still with the advancement in plastic surgery techniques, the retroareolar, in older times it was difficult to reconstruct the nipple and areola, but now can be easily saved or reconstructed. So centrally placed tumors, they are more difficult compared to peripherally located. So that's a relative contraindication. Okay, then multicentric tumor. Multicentric means breast divided into 4 quadrants: upper outer, lower outer, upper inner, lower inner. Now there are two terms, multicentric and multifocal. Again, very important question. Multifocal means multiple foci of tumors but within one quadrant. So this is multifocal. But if 2 or more quadrants are involved, then it is called multicentric. Now multifocality is not a contraindication, because if there is one quadrant involvement, even if there are multiple foci, we can still do quadrantectomy, right, which is one of the types of BCS can be done. But if it is multicentric, BCS cannot be done because more than 2 quadrants have been involved. Okay. Then diffuse microcalcification, again contraindication, because you know microcalcification is nothing but it's indicative of a malignant focus, right? Macrocalcifications are seen in benign lesions, microcalcifications are indicative of malignant focus. So diffuse, scattered all around the breast, multiple foci of microcalcifications, again a contraindication for BCS. Then radiotherapy, previous history of chest wall radiotherapy. This is not directly related to surgery but indirectly, because after BCS radiotherapy is mandatory. Why? Because we are doing a local resection, we are not removing the breast, we are just removing the lump. So chances of recurrence will be higher, and to curb that risk of recurrence, we have to give radiotherapy after all forms of BCS. So radiotherapy is mandatory. That is why any contraindication of radiotherapy automatically becomes a contraindication for BCS as well. So previous history of chest wall radiation, surgery can be performed, but radiotherapy should not be given because of toxicity. Again, patients with connective tissue disorders like scleroderma, increased sensitivity of the radiotherapy, right? So again, they should be avoided for radiotherapy. So this is the list of there are few others like low socioeconomic status, again a relative contraindication, and one more, persistent positive margin. Repeatedly you are attempting BCS but still the margin has come positive. Second time again you have attempted BCS but again the margin. So after 2 or 3 attempts of BCS, if the margin is consistently coming positive, so this situation is called persistent positive margin, positive for malignancy. So then you should abandon the procedure of BCS and you should switch on to the mastectomy. Now look at the choices. Multicentric tumor is a contraindication. Large tumor related to breast size, contraindication. Prior chest wall radiation, contraindication. Now less than 4 centimeter tumor, so small size tumor with N1 lymph nodes, BCS can be done. So it's not a contraindication. Okay, so next is a 22-year-old lady presents with a palpable breast lump, no history of trauma, no discharge, no fever. Mammography reveals a well circumscribed, to be noted, oval mass with fat density, with fibroglandular tissues surrounded by a pseudo capsule, no calcification, very very important, no architectural distortion, overlying skin thickness or no nipple retraction, right? So this is classified as Biretes. Is very very important again from your exam point of view. Biretes is breast imaging reporting and data system. So basically based on mammographic findings or ultrasound findings, the findings are described by the radiologist as one of the Biretes classes. Now that gives you an idea about the nature of the findings. So what are the classes, right? So 0 to 6, 0 is indeterminate, that means it's incomplete, so we need to do additional imaging. 1 is negative, 2 is benign, 3 is probably benign, 4 is suspicious of malignancy, 5 is highly suggestive of malignancy, and 6 is biopsy proven malignancy. Now in this case where our findings fit, it's a well circumscribed tumor, no history is not suggestive of any malignancy, young patient, again very important, young patient 22, you don't expect malignancy, you expect lump to be benign. And the findings also, well circumscribed lump, oval mass with fat and fibroglandular tissues, with the pseudo capsule, no calcification, no architectural distortion. The features of malignancy on a mammogram, there are 4 main features which you should look for. One is irregular high density mass, which is not here. Second, architectural distortion, again not seen in this case. Third, speculated or irregular margins, which is not here. And last is the microcalcifications. So again not present in the current case. So none of the malignant findings is seen. So it's a purely benign looking lump on mammogram. So purely benign is Biretes 2. So the Biretes 2, that means B2 only. So that's the answer. Okay, so this is how we calculate the Biretes class of the patient.